Part 1. Overview of MIPS and the SSR. What is the SSR? The American College of Surgeons Surgeon-Specific Registry is an online quality improvement tool and software application database that allows surgeons to log and track their cases and outcomes in a convenient manner. And so why use the SSR for MIPS? The ACS recognized the need to help surgeons participate in an increasing number of regulatory programs for the individual provider. The SSR is both a MIPS qualified registry and MIPS qualified clinical data registry, or QCDR, for the 2017 program year, and has incorporated surgical measures and improvement activities for MIPS submission for the individual surgeon. What is MIPS? The Centers for Medicare and Medicaid Services, CMS, Merit-Based Incentive Payment System, or MIPS, is the default pathway of the Quality Payment Program, or QPP, where eligible clinicians submit quality data to earn a performance-based adjustment on their Medicare payments. And there are 4 performance components, or categories, of MIPS. First, there's the quality component, which replaces the PQRS program, the Advancing Care Information component, which replaces the EHR incentive program and meaningful use, the Improvement Activities component, which is a new program, and the cost component, which replaces the value-based payment modifier. For the 2017 MIPS program year, the SSR is supporting the Quality and Improvement Activities components. A little information about MIPS scoring and payment adjustments. Your performance in each of the 4 merit-based incentive payment system components makes up your MIPS final score, determining your payment adjustment. Payment adjustments can be positive, negative, or neutral. Each MIPS component is weighted differently in calculating the MIPS final score. And as you can see here, quality is weighted as the highest component at 60%. Next is ACI at 25%, then improvement activities at 15%, and for 2017 only, cost is 0%. Since CMS does not have data yet to calculate cost, it is not applicable for this year. And then payment adjustments are applied based on your performance 2 years prior to the calendar year. Therefore, a surgeon who is a MIPS participant in 2017 will receive a payment adjustment in 2019 based on 2017 data. For 2017 MIPS participants, a maximum of a 4% payment adjustment is possible in calendar year 2019. And as you can see here, the payment adjustments increase as the years go on, with 2020 being at 5%, 2021 at 7%, and 2022 and onward at 9%. As stated before, the SSR is supporting the quality component for MIPS, and there are 2 quality reporting options for surgeons to choose from. First, we have the quality option, which is known as the General Surgery Specialty Measures Set. A little bit of background information on that. The General Surgery Measures were originally developed by the ACS as the General Surgery Measures Group for PQRS 2014, and those measures are still relevant today. The 2017 General Surgery Specialty Measures Set includes 13 measures, including 4 outcome measures and 9 high priority measures. The other option being offered by the ACS SSR is the Surgical Phases of Care Measures QCDR. The Surgical Phases of Care measures were developed by the ACS in 2015 and were designed to encompass all surgical specialties. The 2017 ACS Surgical Phases of Care measure set includes 10 measures, of which 3 are outcome measures. And here is an overview of the 13 measures available in the 2017 General Surgery Specialty Measures set. I'd like to draw your attention to measures 21 and 23. These measures should look familiar for anyone who has ever reported the Perioperative Care Measures Group in the past, before CMS had retired that option. And then if you look further below, you will see the 5 measures that were developed by the college, the general surgery measures, 354, 355, 356, 357, and 358. As you can see here, 4 of those measures are outcome. And then 358 is the measure that uses the surgical risk calculator. So this is a measure that requires that the clinical action be done preoperatively. Aside from that, you'll notice that 21, 23, and then 354 through 358 are bolded. And these 7 measures are measures that are procedure-based, meaning that the CPT codes for these measures, the eligible CPT codes, are actual surgical procedures, whereas measures like 47, care plan, and 130, documentation of current medications in the medical record, those use office visit consultation codes. This means that you'll report these encounters separately from the other cases that are surgically related. So most likely you are not going to have a consultation the same day of the surgery, so you cannot report, say, measure 355 and measure 130 in the same case in the SSR. And then here we have an overview of the 2017 ACS surgical phases of care measure set. So the measures are divided by surgical phase. So we have the preoperative, perioperative phase, intraoperative phase, postoperative phase, and post-discharge phase. And the measures, this doesn't really have any bearing on how you report the measures, but the idea here is that we are trying to measure surgical care across the continuum for the patient instead of just on reporting encounters. You'll notice one familiar measure here, measure 358, the risk calculator measure. That is the one MIPS measure that is available to you. The rest are what are known as non-MIPS measures, and this just means that these measures were developed by this specific organization and are specific only to ACS. You'll notice you have the 3 outcome measures below: unplanned reoperation within 30 days of the postoperative period, unplanned hospital readmission within 30 days of the principal procedure, and surgical site infection. These 3 measures are modified versions of the general surgery measures that are currently available. And you'll notice here that we have some composite measures, and we will go over those in a little more detail as we discuss and demonstrate how to report these in the system. But all you need to know at this point is that composite measures are comprised of several components, which must be answered individually, almost like measures within a measure. And the measure can only be met if all components have been answered. And even then, there's still a caveat. We will go over that in the demonstration portion of this educational video. For 2017, the SSR is also supporting the improvement activities component of MIPS. For IA attestation, eligible clinicians may attest to and submit IA data through the SSR for 2017 MIPS, and there are 72 surgically relevant IAs to choose from. The attestation requirements are as follows. To earn the maximum score for the IA components, ECs must attest to 40 points worth of IAs, and each IA is assigned one of 2 weightings. There is a high weighting and a medium weighting, and for the high weighting, the points can range from 20 to 40 points, and for the medium, the activity can range from 10 to 20 points, and I'll explain that momentarily. So how many IAs an individual EC must attest to and the amount of points an IA is worth is then dependent on the size of the group for which the EC is a part of. So if you are in a group with more than 15 clinicians, then high-weighted IAs are worth 20 points and medium-weighted IAs are worth 10 points. On the other hand, if you are in a group with 15 or fewer clinicians, are in a small practice or in a rural area, then high-weighted IAs are worth 40 points and medium-weighted IAs are worth 20 points. I would also like to draw your attention to what CMS defines as an eligible clinician. And per their verbiage, for 2017 and 2018 MIPS performance periods, the following clinician types can participate in MIPS: physicians, physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetics, and other staff as well. So the point here being that when you are determining which category you fall in for how many points the IAs are worth to you, you have to count, you cannot just count the surgeons in your group. It is surgeons plus the other eligible clinicians you see defined here. And here are just a few examples of some improvement activities. You'll notice that each activity has a subcategory. This doesn't really have any bearing on what you attest to. It is just a way to intellectually organize the improvement activities by category. And you'll notice that you have the improvement activity name and description. And then to the right of that, you have the weighting. Most IAs are medium weighted, whereas fewer of them are high weighted. And you may find the full list of IAs available through the SSR in the link here. Next, we will discuss the Pick Your Pace program, which CMS has set forth for the 2017 year. CMS has designated 2017 as a transition year. Therefore, they are allowing physicians to test the program, if you will. And so if you are in the MIPS program, and if you choose the MIPS track of the quality payment program, you have three options, but three viable options. So option one, submit something. This is the test pace. So if you submit a minimum amount of 2017 data to Medicare, for example, one quality measure or one improvement activity, you can avoid a downward payment adjustment. Option two is to submit a partial year. If you submit 90 days of 2017 data to Medicare, you may earn a neutral or small positive payment adjustment. And option three is to submit a full year. If you submit a full year of 2017 data to Medicare, you may earn a moderate positive payment adjustment. And then your fourth option is to not participate. Not participating in the quality payment program will earn you a negative 4% payment adjustment in 2019. And now we'll go over each of the Pick Your Pace options in a little more detail. So option one, test the QPP, submitting something. Submit a minimum amount of 2017 data to CMS, and this will allow you to avoid the 4% penalty. What is a minimum amount of data? This could be one quality measure, for example, for one patient, or one improvement activity for 90 days, or the required base score for advancing care information measures. And remember, you can only fulfill the ACI measures through your EHR. Option two, participate for part of the calendar year. Physicians may submit a minimum of 90 days of 2017 data for at least one MIPS category up to any combination of all three categories. And this will allow you to potentially earn a positive payment adjustment, depending on your performance. What can be considered a partial year of data? One or more quality measures for at least 50% of all payer patients, and or one or more improvement activities for 90 days, and or the required base score for advancing care information measures. And you can start this anytime between January 1st and October 2nd. And lastly, option three, participating for the full calendar year. Physicians may submit a full year of 2017 data on all three MIPS categories, and this will allow you to potentially earn a positive payment adjustment, again, depending on your performance. It is the best possibility to earn the largest payment adjustment. Full participation in MIPS means that clinicians should at least meet the following criteria: 6 quality measures, including one outcome or high priority measure, for at least 50% of all payer patients, and 4 medium-weighted or 2 high-weighted improvement activities for 90 days, and reporting the advancing care information measures. And so a little bit of a comparison between the full year participation and the partial year participation. So For the full year participation, it is the best way to get the maximum adjustment, and it does give you the most measures to choose from. And additionally, it prepares you the most for the future of the program, as this transition year with the Pick Your Pace program will not be in effect indefinitely. And then you have the partial year participation, in which you report for 90 days. You can still earn the maximum adjustment with this option, and it does most likely mean you'll be submitting less data than you would otherwise for the full year participation. So those are just a few things to consider in regards to how you decide to participate for 2017.